Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. This episode is sponsored by apnea. We sometimes receive requests from our listeners. One request was to discuss continued sleepiness in well-treated obstructive sleep apnea. This is a common clinical scenario, and questions were raised about both the diagnosis and potential treatment options. We reached out to some experts in our field to shed some light on this. Dr. Kingman Strohl really needs no introduction. He has a background in clinical pulmonary and sleep medicine, with specific expertise in respiratory control, mechanics, and physiology. He was on the team that developed the Berlin questionnaire and has been researching this area for decades. Dr. Donovan is a pulmonary, critical care, and sleep physician at the VA Puget Sound Healthcare System, associate professor of medicine at the University of Washington School of Medicine, and director of the VA Collaborative Evaluation Center in the Denver-Seattle Center of Innovation for Health Systems Research. Welcome to you both. Thanks for joining us today.
Thank you.
Thank you so much.
Let's talk about sleepiness and obstructive sleep apnea. So, how long after starting PAP therapy should someone feel better?
I think that's a great question, and I think the optimal word there is should, because I think we all know some patients who start to feel better kind of immediately after they start to use CPAP. But is that the norm for all patients who are treated for obstructive sleep apnea? Some illustrative findings come from the European Sleep Apnea Database, where they followed patients from diagnosis over time and looked at the patients who had excessive daytime sleepiness at baseline, and then were found to have excessive daytime sleepiness at subsequent follow-up visits. And what they found is that 40% of patients who had excessive daytime sleepiness at baseline still had excessive daytime sleepiness within the first 3 months. And then patients who had follow-up after that, excessive daytime sleepiness was closer to 20% and tended to go down over there. Now, granted, there is some definite selection bias in the way this data arises. You know, patients who are seen earlier post-diagnosis may be having problems with therapy and maybe having issues, but it's definitely aligns, at least with my personal clinical practice, where it does take some patients time to get used to treatment.
So I'm surprised it's 40% at 3 months.
Yeah, and I think it's important to note that this isn't 40% of all patients. It's just the 40% of patients within the sample who had follow-up.
Okay, that makes more sense. Okay.
And so in short, in usual care, we don't know exactly what the optimal timing is. But there was a recent Delphi consensus document, Steer et al., published in Sleep Medicine in 2023, where a group of experts, talked about this issue and discussed timing for follow-up of excessive daytime sleepiness, and informed by analyses such as those from the European Sleep Apnea Database that was published in Frontiers Neurology in 2021. They came up with the consensus that we should be assessing for excessive daytime sleepiness at 6 weeks and then at 3 months, but really not considering that patients have residual excessive daytime sleepiness until patients are about 6 months post-treatment. Once patients have been able to get used to treatment, try different strategies, troubleshoot problems, and address issues with therapy, as well as look at other causes of sleepiness, as we'll discuss later on.
I mean, I think that's fair, right? 6 months is reasonable. Is that the same for treatment regardless of what that looks like? Meaning, is that the same for Inspire and oral appliance therapy?
Yeah, so I think when it comes to Inspire and oral appliance therapy, we do have less data around how people do over time. But I think that same time frame seems pretty reasonable. So, following, I defer to Dr. Strohl about, following patients post-Inspire, because in my clinical practice, I really don't have that many patients on Inspire. But at least with oral appliances, depending on the titration protocol that's being used, you need to allow at least a few weeks to a few months for patients to really be at their at peak therapy and assessing the effective treatment.
So, Dr. Stroll, how do you set expectations around treatment of sleep apnea?
Well, I think the first thing is to identify something that is patient-based in their symptoms, and sleepiness is the most obvious, but it could be other things like waking up refreshed,
Mm.
that they'll know that if they're well treated, that these particular problems will mitigate, that is, get better. And so they'll be much more motivated to continue to try to use it. About 40% take it to it like a duck takes to water. About 40% have to kind of struggle with it. And about 20% you eventually kind of throw up your hands or you try to do other things. But that first month, first week, first month of therapy to get adequate therapy is an important period of time. We probably don't follow up as quickly as we should, at least in the United States, because our return visits are usually spaced more apart, and then the group that really has brought this into focus are those of commercial truck drivers. When can they go back to work, and when are they not sleepy? And I think that's uh, we fall back on some of the data that suggests that maybe within a week they feel better, but it takes 6 to 8 weeks for maximal effect, and they may not be objectively better, but they're subjectively better in that they feel as though they can perform their job.
So let's talk about that sleepiness. So when we were preparing for this, you talked about multiple pathways for sleepiness. Tell me about this.
I'm fairly frustrated by the symptom of sleepiness, mainly because I can produce sleepiness as much by sleep deprivation as I can by having a person with narcolepsy walk
Mm.
into the clinic, and so it's a monolithic sort of symptom that also has a spectrum to it that overlaps with both behavioral as well as medical reasons for it. And so and then the sorts of things that we treat it with, we treat it monolithically. We don't really have specific targets for specific people, so we don't personalize it very well. So my particular approach is to focus on the first month, 2 months on therapy. And with Inspire, if it's a little different process, you turn it on a month after it's been implanted, you have them adjust it. They're fussing about it. They're actually spending more time thinking about their sleep than probably probably the CPAP people do. But they tend to again about 4, 6, 8 weeks is when you start to say, well, are they going to get better? The curious thing that Lucas brought up is that some people have a euphoric response in the first week. And that's thought to be because hypoxia inhibits the synthesis of some of the alerting agents. And so, in particular, serotonin. And so there's a release of serotonin because you're no longer hypoxic.
Mm.
And they look back sometimes wistfully and saying that first week was so wonderful. Why
Mm-hmm.
can't I get that again? And you have to talk them through that as well. That's not a big group though. That's probably 5 to 10%.
Mm. So, do you think that we will find phenotypes for sleepiness with different mechanistic backgrounds?
Well, I think we have to find
Mm.
phenotypes. I mean, and that will require some fairly, hard work in CNS monitoring and drug trials, head-to-head trials, and knowing resting brain networks and how people, what parts of their brain perceive, because it comes out the same way. I mean, sleep apnea, sleep deprivation, lack of orexin, even medications that produce sleepiness. They can't all work through the VLPO, huh?
Right.
Maybe they do, but 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 they the sleep is both a global as well as a local
Mm.
phenomenon in the brain, and so these drugs are just used indiscriminately for sleepiness that presents with different diseases.
So tell me about this specifically in terms of continued hypersomnolence with well-treated obstructive sleep apnea. What's the theory behind why this happens?
Well, the animal models produce a massive amount of intermittent hypoxemia, or a prodigious amount of intermittent arousals, and can produce sleepiness. And both
Mm.
of them seem to impact upon cells that make or release adenosine in the forebrain. And they can show that there is loss of those cells. And there is some capacity for recovery if you stop that that big challenge that they do to mice. I mean, you can do things to mice you can't do to people. But intermittent hypoxemia, when it's done to people, as some of the studies in Boston, they increased blood pressure, but they didn't necessarily, as intermittent hypoxemia during sleep, increase blood pressure, but didn't really increase their sleepiness. So we just don't, and there are other examples of that is that it's probably the sleep disruption. It's
Mm.
probably is the major contributor to it, even though what 20% of all obstructive apneas aren't accompanied by EEG evidence of a 3-second arousal.
Mm.
Uh, we have imperfect tools to measure the brain responses, and we have imperfect tools to understand its recovery.
So you were teaching me about Dr. Thomas Roth's work on hypoxia and sleepiness.
The studies in the 80s, and it's worthwhile for maybe junior people to go back to sleep 1990s, 1980s, and he took a really interesting comparison. He took COPD patients and then he took sleep apnea patients, and they were kind of equally hypoxic. Uh, COPD patients more hypoxic in terms of steady state, and intermittent hypoxemia from the OSA patients. But what he could find was really that the sorts of things that were affected by sleepiness were found in the OSA patients, but they were not found in the COPD patients.
Hmm.
And his conclusion was it wasn't hypoxia that was doing the, the symptom presentation of sleepiness in OSA. And so I think the idea and people aren't sleepy if they're in Lhasa. If they're in Tibet, they're not walking around falling asleep. So everybody says, "Oh, they live up there." But if you go ski, you go up there to ski. You go up to 12,000 feet, then take the lift to 14,000 feet, and you feel great. And you come down, and you're tired, and you fall asleep easily that night. But the next morning, you don't fall
Mhm.
asleep in your breakfast.
So is this something that you can see with mild obstructive sleep apnea, Lucas?
Yeah, I mean, certainly you can see sleepiness with mild obstructive sleep apnea. And the severity of obstructive sleep apnea hasn't really been associated with the appearance of sleep apnea with residual sleepiness despite therapy.
So that's interesting because I often will think about that and say, okay, well, if I have somebody who has moderate sleep apnea, they're not hypoxic, they're well treated on their CPAP, but they're still sleepy. Is this the right diagnosis? Or when do I have to start looking for something else?
Well, that's always in the back of your mind.
Right.
Yeah.
Yeah, I think that there is, and the opposite. The tendency is if they had terrible sleep apnea, that they must not have anything else.
Mm.
So, so you get hit by both sides when you're starting to follow up on these people on whatever therapy they have for the OSA. If they were mild before and they're still sleepy, you sort of perhaps look at things like sleep-wake cycle, sleep opportunity, drugs, other diagnoses. And if they're severe, you usually ignore the fact that well maybe they have another reason for it.
Mm. So, Lucas, what's your systematic approach to the sleepy patient with well treated obstructive sleep apnea?
Yeah, I think just like when we're faced with any inadequate response to any treatment or course of therapy. As the treating clinician, we need to query our own diagnosis and approach, and ask the questions: Did I get it wrong? Is this the wrong diagnosis? Am I treating obstructive sleep apnea, or is this another cause of sleepiness? And so first, do they really have OSA? And I think for many patients we take care of, we maybe aren't taking care of them right at the start. Maybe they had a more remote diagnosis of OSA. So it always behooves us to go back and look at the test. Sometimes the diagnosis might not be right. So first off, querying that initial diagnosis. And then the second thing I think about is, do they have sleepiness? For here it's really important to differentiate drowsiness from fatigue, because that opens up a whole different differential diagnosis if it's more fatigue and not actual drowsiness. And then I get into what else could be causing the sleepiness. And first on the list, for me at least, is insufficient sleep. And querying, are they getting a sufficient amount of sleep at night? Has that been changing over time? Did something change for them, in their home life or with their work, where they're no longer able to get 7 to 9 hours of sleep at night? And then the other things you need to think about is medications. What are we as a healthcare system doing that could be causing this? Common culprits are sedating antidepressants, sedating antipsychotics, opioids. Beta blockers can sometimes cause sleepiness. And then the medications that we typically know cause sleepiness, benzodiazepines, sedating antihistamines, hypnotics. Just really reassessing the medication list. And then considering other diagnoses, mental health disorders, mood disorders, substance use often can result in sleepiness. Endocrine disorders, hypothyroidism, but also hypoadrenalism, chronic kidney disease, type 2 diabetes can oftentimes create sleepiness. And then neurologic disorders, traumatic brain injury, multiple sclerosis, as well as neurodegenerative diseases. Now, we don't need to, conduct a $1 million workup or get confirmatory testing for all these conditions, but at least considering it and going down the list in a systematic way of what other conditions could be causing this is important. And then moving on to the sleep disorders. Are there other sleep conditions beyond obstructive sleep apnea that I haven't considered or may have crept up? Is there another sleep disorder that's resulting in insufficient sleep opportunity? Do they have restless legs? Do they have have they developed shift work disorder? Is there a circadian rhythm disorder that I previously hadn't considered? Other things like central disorders of hypersomnolence among people with OSA. Idiopathic hypersomnia is something it's tough to diagnose because it's not idiopathic, but narcolepsy, of course, is something you should certainly consider asking about symptoms of cataplexy. Asking about the time course of their hypersomnia, and then considering other sleep-related breathing disorders, including hypoventilation syndromes, which can cause hypersomnia that doesn't improve with PAP in some situations. And then finally, other sleep disrupting process like periodic limb movement disorder.
Let me jump in for a second because it reminds me of one of my more professionally embarrassing periods of time in which I've been in practice long enough that I have these patients I've had for 10 years in the practice, and I had a lady that had diabetes and had sleep apnea and was well treated, and she kept complaining about her sleep for a long period of time, and I'm coming in and I was adjusting her CPAP and all that, and one of the other neurologists who was taking care of her for some other issues started casually asked her about the restless legs, and sure enough, it was all restless legs, but it was
Oh
all
my
hidden
gosh.
by the peripheral neuropathy that she had with her. So I would always ask that. And the other is, what's nice to have fellows around is
Mhm.
that they ask all the questions. And sometimes in patients that occasion to try to recruit patients with OSA from my own practice, and I said I would recruit people that were under the age of 65, and then I looked at my practice and they're all over the age of 65. But the sorts of things, they're not immune from other sleep disorders if they have sleep apnea and you've been treating them even for some period of time.
So let's say you are knee deep in this evaluation. You've got somebody with sleep apnea, they're well treated, they're not hypoxic, they're not on any sort of sleepy meds, there's no RLS, there's no, the thyroid is fine, all of that stuff. And you move forward and you do the, PSG on treatment, you do your MSLT, and you
Mhm.
have mean sleep latency of 16, no SOREMs, but they fall asleep in every nap. What do you do?
Yeah, I think
You
here,
tell them they don't have narcolepsy.
yeah, absolutely. And I think here it's just, we need to take a patient-centered approach
Mm-hmm.
and not necessarily look at one number. The mean sleep latency could, in isolation could put us down, one set of one path. But if the patient's telling you, I'm still sleepy. When I talk to patients about sleepiness, I try to personalize it into things that are meaningful to them, and find concrete situations that are relevant to their daily life. Of course, there's the clear safety benchmarks and the things that that we need to understand in every patient. Drowsy driving, drowsiness, and other situations that impair safety. But there's also sleepiness that impairs their quality of life, or their livelihood, or if their mean sleep latency is 16, but they're falling asleep in work meetings and are at risk of losing their job. That's one thing. And then also if they're unable to do things they enjoy, like they can't finish a book, they can't finish a television series or a conversation with their spouse. Those are important things. And so understanding those, how sleepiness affects their life, and what are those scenarios where they become sleepy, can be helpful in targeting whether or not the next steps in treatment, next steps in addressing this residual sleep apnea is going to be important for them, and it's going to be something that they value. And then you can also use that to track things over time. And so, I think as clinicians, we like numbers, we like objective tests, and we even like standardized PROs like Epworth or Promise. But finding these concrete scenarios for each patient can really be helpful in terms of following the course in a way that's meaningful to them.
So let's take a short break, and when we come back, we'll talk more about the evaluation of persistent hypersomnia despite well-treated obstructive sleep apnea. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Dive deeper into the future of sleep apnea therapy with the Apnea Sleep Care Program. Once we receive the PAP referral, our team springs into action, offering patients a seamless transition into therapy. Patients start by selecting how they want to begin their sleep journey: in-person care, virtual care, or self-directed care. With ongoing therapy support, including coaching, digital resources, and video assistance, we're committed to ensuring every patient's success. We stay connected with our patients with live calls, texts, emails, and IVR, all designed to make adherence a breeze. And with our supply schedule program, replacements are delivered like clockwork. Experience the difference of an enhanced sleep therapy program with Apria Healthcare. Discover more about our innovative sleep program online today at apria.com.
Welcome back to Talking Sleep. We're talking with Dr. Kingman Strohl and Dr. Lucas Donovan about persistent hypersomnia and obstructive sleep apnea. So, Dr. Strohl, tell me about passive sleepiness versus active sleepiness. What does this mean?
Well, I in my own mind, I try to define what kind of sleepiness a person is complaining about. When does it occur and how does it occur? And the Epworth is a good example of falling asleep when you're inactive or passive. That is, if you fall asleep listening to me on this podcast, I'm not worried. But if I fall asleep talking to you on this podcast, I might get worried about sleepiness. So it's the active sleepiness is falling asleep on the telephone, talking to your mother, your son, and passive is really, Donovan talked about it. It's falling asleep in an inactive period of time watching TV, uh, and not terribly terribly engaged in what's going on. That is usually terminated pretty easily by getting up, walking around, and people use that as a countermeasure.
Mm-hmm.
So then the other is who notices the sleepiness, and who does it bother? Mild sleepiness is generally perceived by the person. Moderate is the person and maybe their immediate family, and severe is noticed by everybody. So
Mm-hmm.
you try to get everyone involved into what this sleepiness is all about, and describe it as sleepiness versus fatigue. I can't get anything done, and sleepiness. I tend to fall asleep. So you have to kind of distinguish those things. You don't fall asleep because you're bored. You fall asleep because you're sleepy, and that's a distinction that sometimes is not made in the patient population in describing what they have. So I try to figure out at what times people are sleepy, and if we then go on to talk about medications, what are the more susceptible times for sleepiness, and how you use or time medications better to mitigate that.
So you had mentioned earlier that there's a difference between objective improvement in sleepiness and subjective improvement. So how long does it take to get objective improvement like improvement in MSLT?
Well, the Weaver article was part of their CPAP over time, followed people out for 6, 8 weeks, and subjectively about 70, 80% normalized their Epworth, but only 40 to 50% normalized their MSLT. Now, the numbers were a little bit different then than they are now, but the major point was that reaching an asymptote for improvement was higher in the self-reported sleepiness than it was for and also for the FOSQ as well than it was for the MSLT. You plateaued at that particular point.
Hmm.
And so that's why I usually sort of think about if people come in at 1 month and say that they're still sleepy, I encourage them to uh, use it regularly or more religiously, and because it can get better over that next period of time. The increment of change is a little bit less, though, the more the time goes by. You also want to sort of make sure, and Lucas alluded to this, is that they're getting adequate sleep. Most people don't know how much sleep they need to not be sleepy. Everyone probably has their own trick, but it's not good enough to sit there and say, get more sleep, because they say, well, how do you do that?
Right.
So
Right.
I usually try to have them stick their wake up time and then move their sleep time 15 minutes every 4 days, move it to earlier in the evening, because people tend to be able to carve off 15 minutes from whatever it is. Of course, you have to say, well, what keeps you up? And,
Right.
and when they tell you, well, what keeps me up is I nap at 7 o'clock at night, and
Right.
then you're right back into the whole thing again. But I think it's interesting that most people really do know how much sleep they need, but they just don't plan on getting it. So even on CPAP, they have to kind of be encouraged. And then the other is their self-awareness of sleepiness. It's you have to kind of realize that pauses or slowing or your own perception of sleepiness, what it is, you're not measuring it. And even anesthesiologists doing their work aren't aware of it when they're asleep. So, so I think I'm always struck by the lack of sort of self-awareness about sleep, as opposed to the self-awareness about nutrition and exercise. I think that's a failure of our educational system.
And that's a whole other topic, isn't
Right.
it?
Because it's hard to talk about. I mean, if people don't have a basic understanding of that they need more sleep to be less sleepy, it's very hard to talk about.
It is. And some people are very rigid in that.
Yeah.
Yeah. I used to get by with 5 hours and now I can't,
Right.
fix it.
Well, I one time in the sleep academic ward, I was down at a high school and talking to teachers about it. The guy goes, "Well, I have a very simple cure for having people not fall asleep in the first period. The people who look like they're falling asleep, I have them stand in the back of the room holding a glass of water."
Oh my gosh.
Don't you realize that probably a 20-minute nap will make them learn faster what you were teaching? But
Wow.
it's really how you can talk about this, the vocabulary, even the language of talking about sleep compared to exercise and I always compare it to exercise, nutrition, and even sex.
Mm-hmm. Well, and you're right, because I think some people just naturally associate sleepiness with laziness. The educational component, there's also that like internal belief system. There's sort of the cultural element. There's a lot of things stacked against us here.
Yeah, deconstructing that kind of stigma is difficult.
So is long COVID syndrome something we should be thinking about in our sleepy patients?
Well, we've been looking at that pretty closely here from a cohort that in the first year or so that we've been following for 2 or 3 years. Sooner or later, they all get sleep studies because no one knows what to do with it. But it's not a large component. Sleep apnea is there, but you sort of don't know what to do with that. And they're sleepy. It's much more fatigue. And the questionnaires can distinguish the two.
When do we start to think about adding a wake-promoting medication, Lucas?
Yeah, so I mean, I think it comes down to, when do we expect things to get better, as we discussed, kind of earlier in the podcast. Really, I think it comes down to, have we gone through a systematic approach to exclude other causes of excessive daytime sleepiness? Have we given the primary therapy sufficient time to work? Have we given the patient sufficient time to get used to the treatment? And are we sure it's working? So once we're sure, and typically that's going to take 3 to 6 months, post start. Are we ready to consider a new treatment? That's when I think we would consider one of these wake promoting agents, when we're really sure this is excessive daytime sleepiness, no other cause, and we've gone through that approach.
Is there value in PSG-MSLT to render this diagnosis?
I think that that needs to really be individualized. I think for most patients, the answer is no. I think one exclusion is our commercial drivers, where there may there's a higher bar to overcome. But I think in general, we tend to not pursue PSG-MSLT. Now we might pursue objective testing to ensure that therapy is working effectively. I think that's something I do routinely. There's no universal consensus on this, but I before starting a wake promoting agent, I tend to want to ensure that that PAP is working effectively. In addition to the download data, I tend to pursue a home sleep apnea testing while patients on treatment.
Oh, interesting. Okay.
And
so you're not relying on the download.
I think personally I've been I've found that sometimes there's enough discrepancy. I think there's been a number of studies that shown this, that I tend to like to see some objective evidence. Now all this has to be tailored to the individual. If there's a If the individual is really sleepy and is, there's a risk to their safety or livelihood from sleepiness, I may be more prone to act quicker and work close and engage in a wake promoting agent while also doing the non-pharmacologic things to address drowsy driving and the like.
What do you start with?
So when it comes to pharmacotherapy, I tend to start with modafinil. I think that there's 4 evidence-based wake promoting agents, 3 with an FDA indication for OSA on the label, and among those, these 4, modafinil and armodafinil are the ones that we have the most experience with. There's no comparative effectiveness studies to steer us, for sure what to one or the other. But in the agents that I've had the most experience with are modafinil and armodafinil. These medications, there's about a half dozen randomized controlled trials in this scenario, where they improve sleepiness to a meaningful degree, and that's where I tend to start. And so with modafinil, you start with 100 to 200 milligrams a day, and then titrate up based on the patient's response over a course of weeks up to typically with modafinil I max out. The max is 400, but I tend to oftentimes that it's more helpful if you split it into two doses depending on the patient's response. But after that, if monitoring for response to therapy as well as side effects, most common of which include headache, which about 15% of people have. There's also side effects including nausea, anxiety, insomnia. And following that over the course of weeks to months, seeing if you've had an adequate response to therapy, seeing if there are following side effects, you may move on to other agents. And so I tend to engage in a pretty in a pretty similar approach where I start with modafinil, move on to armodafinil, and then move on to solriamfetol.
What I'm struck by is all these medications have a fairly quick onset and then drift down over the next 3-4 months, but not by much. The biggest change in the first week or first month. And they all have the same effect on sleepiness. So what's sleepiness? It's not, it's not just a dopaminergic, or it's a adrenergic, or it'll be interesting when we get these orexin agonists to see whether or not there's the same effect of orexin agonists.
Yeah, it'll be very interesting. So then when you talk about solriamfetol, is that something that you would then choose if they have not either had a side effect or maybe not as much clinical improvement on modafinil or armodafinil? Or is there another reason you would choose that, like the oral contraceptive interaction?
Yeah, the oral contraceptive interaction, I think, is a really, really important one for individuals who are using oral contraceptives. The modafinil and armodafinil will impact metabolism of those agents and potentially reduce their effectiveness. And so individuals who are on oral contraceptives, I that's the situation where I move to solriamfetol as the first choice, and not the third choice. And another practical reason why I choose solriamfetol as the third choice is just because I due to the requirements for prior authorizations.
Yes, so, the one thing that unites us all.
Yeah. So I'm fortunate. I work in the Department of Veterans Affairs, and I have to say that I'm not speaking on their behalf here. This is just me. Gotta make sure that's clear. But it's pretty. Our pharmacists are really great to work with, and when we talk to them about the issues we've been having. It's actually very straightforward and a streamlined process for us to move on to other medications which might be non-formulary. And so really thankful for the pharmacy colleagues who help as we move through this process.
Do you ever use solriamfetol and modafinil together?
I personally have not done that. And I'm, I think before I would do that, I would probably check with a pharmacist. That's kind of like my go-to. But I, theoretically, the mechanism of action is, I guess, first off, the mechanism of action for modafinil and armodafinil is somewhat obtuse, but I don't see why it would necessarily be a non-starter, but I would probably want to check with a pharmacist before I did it. I don't know, Kingman, have you ever done that?
Yeah, we've done some mix and matches because smaller doses that don't have side effects and strategic doses, and even using things like Ritalin strategically for people who want to drive and do various things like that. What I'm it's frustrating because the histaminergic, the inverse agonists, those are not controlled substances. And, when you start thinking about why couldn't that, maybe in the world in which there is all generic drugs, that maybe that will be the one that takes over. I mean, the use of modafinil, armodafinil, until it got to be generic, was the same sort of, tread on eggs on this. But people before that used, Ritalin, used short acting and long acting and different cocktails for that. Now you have to watch out because that, your blood pressure effects and your side effects. And we recently had to wean somebody off of amphetamine that had been on it for a long period of time on the outside. It worked for him, which was frustrating because it worked for him, but he still had that diagnosis. So I think you sort of start with what the practice guidelines tell you to start with, and you start to adjust one way or the other, making sure that your diagnosis is correct and that they don't have something like idiopathic hypersomnolence, or they don't have something that in which you might need to use are indicated for other drugs.
So that's 3, right? You talked about 4. So you mentioned modafinil, armodafinil, and then solriamfetol. What's number 4?
So the fourth evidence-based medication for residual sleepiness in OSA is pitolisant. And so this is been demonstrated in the HOROSA trials that were recently published, where patients with obstructive sleep apnea and excessive daytime sleepiness. In one of the trials, I can't remember if it was HOROSA 1 or HOROSA 2, included patients who were adherent on CPAP, and one included people who did not start CPAP. Similar to the trials for modafinil, armodafinil, and solriamfetol, there is a meaningful benefit for in terms of the Epworth Sleepiness Scale change relative to placebo. I believe it was about 2.5 points for pitolisant over placebo. And so this is another treatment that we can consider. It's currently not FDA approved for the treatment of excessive daytime sleepiness. The other thing to consider is that the dosage used in the trial is slightly different than the dosage that's approved for narcolepsy. I'm not sure exactly the reasoning for that. I'm not sure the rationale there, but that's one thing that we'd have to consider. That it's not markedly off. I think they reached a maximum dose of 20 milligrams in the HOROSA trials, and the dosage range for narcolepsy is the the 8.9, 17.8 milligram.
35.6, yeah. So that's interesting. So maybe we'll see that down the road for us, right?
Yeah.
So what else is coming down the pipeline for us? I mean, what do you see the future of treating persistent hypersomnolence and well-treated obstructive sleep apnea? What does that look like?
I think if we know more about what if we know what the targets are, we know what the receptors are. You're looking at this patient. Do you say that they have a problem with their dopaminergic system, their rexogenic system, have a problem with reuptake inhibitors and norepinephrine and things of that sort? If we knew how to do that, we might be able to pick one drug versus another drug, or we might be able to combine drugs to know that they hit different parts of whatever this sleepiness tendency is in the brain.
Mm.
We haven't talked about use of things like sodium oxybate, which would make them sleep deeper to be able to be less sleepy, which works, paradoxically in narcolepsy. But is there residual microarousals in well-treated OSA? I mean, that's a good question. The other would be you have to be careful about polypharmacy in this. We probably don't know all the interactions that happen with the psychotropic drugs, and some people who prescribe those for other conditions may not know what we're trying to do in sleep.
Mm.
So I think the next, other than a good history, good physical, being able to figure out what people are doing, is really brain imaging to try to be able to know what's going on. Uh, but that's going to be, it's going to be experimental for a long time. It's not going to be mainstream. People don't do mainstream resting brain networks in our institution or in many institutions, even in academic centers, more in Europe than the United States.
Is there something predictive on either polysomnography or pattern of CPAP download utilization? Is there something predictive of the patients that are going to respond and be less sleepy with PAP alone versus the ones who need medications?
I don't know of any of that.
Mm.
Look, I mean, the new way of looking at the brain mapping is 128 electrode array, and that gives you a kind of a three-dimensional electrical excitation of the brain in both wakefulness, and in different tasks in wakefulness as well as during sleep. And it's a poor man's functional MRI, and it's it would be nice to work it into our sleep labs because it might elevate the practice of the sleep lab in other people's eyes as to be a very important brain place, which it is, instead of, oh, that's just a sleep study, right? But so how are we going to treat excessive daytime sleepiness and residual OSA in the future? Probably the same pathway of diagnosis, therapy, reassessment, and impact. The other things that we were talking about in general was the idea is we really don't have a lot of long-term studies of impact in these residual sleepy. I mean, what impact does it really have other than what we have for improving quality of life? Does it have any impact negatively or positively on their health? And the other would be do you really use a lot of stimulants in the older population? That's maybe vulnerable because of their differences in the pharmacokinetics as well as what goes on. I mean, the barefoot skier at 85 sleeps just as well as the 25-year-old, but as you get older, you have all this other baggage.
That's very wise. Lots of
Well,
wisdom.
that was a study in Seattle. It was great by the nursing school. They screened 5,000 people over the age of 80 to try to find people who were healthy, and found about 5 to 10 that were just otherwise healthy, did sleep studies, and they did fine.
Oh, wow.
So I think that's important to kind of realize and it pokes a hole in the idea that, sleep goes down. It's just other things. You adjust other things. In fact, your sleep satisfaction scores usually adjust to what your peers are doing. And if they have what we think is objectively poor sleep, but they say they're doing okay, their peers usually say they're doing okay. But that's another story as well. So in terms of I think the crucial group is that group between the ages of 40 and 60 that have severe OSA, have had it for some period of time, of which we do not know what the duration of this illness is. And we have some exposure to repetitive arousals during sleep, short sleep, which also accompanies OSA. Because if you sleep with an OSA, say you sleep with an AHI of 30 for 8 hours, is that the same as 8 hours without a 30? No, you probably need more sleep to be less sleepy, but you can't afford it because of your work. And you do that, rinse and repeat for every night for several years, you can get into a lot of mischief and then develop the other unhappy travelers in that group, which is hypertension and cholesterol and weight, exercise. So I think you sort of have to kind of stabilize the patient and then get greedy about their health, weight loss, more exercise, more light, interactions with others for their brain health and things of that sort. And that may include the additional impact after 3-4 months that we don't think about routinely.
So any final thoughts for us, Dr. Strohl?
Well, I think that looking back at what I've seen occur, I think the next what are people going to be worrying about in 5 to 10 years? What are you going to be worrying about? You're going to probably have new drugs. You have new targets. You have to learn all these different pharmacokinetics of all these different neurotransmitters. I don't think we're going to learn about well, we may learn about new things in the brain. There's some interest in the brain making soporific molecules, even in the presence of orexin deficits. So there are inflammatory mediators that are not only affect brains directly, but they probably also operate as physiologic monitors. So
more to come.
Yeah. Which maybe we should be doing more LPs in these people, right?
I hated LPs. I hope not.
But the LP, in terms of the proteomics of saying what is it, would allow us to get more as that gets to get. Well, they're going to go to not just what they find in the LP. They're going to look and find if they can see it in the plasma. I mean, things in the orexin now. They have people say they can get orexin in the plasma at different levels, but that remains to be really well shown.
Dr. Donovan, final thoughts?
Yeah, I want to echo everything that Dr. Strohl said. I'm excited to see the new treatments that could be coming down the pike and allowing more options for our patients. And I think it'll like many common clinical scenarios with what will ultimately be incumbent on us is personalizing the care to our patients' preferences and engaging in shared decision making around these long-term medications to address sleepiness. And as we learn more about the pathophysiology of this phenomenon, hopefully there's new treatments. But I think in the meantime we need to have discussions with our patients about these medications, potential impacts on blood pressure over time, monitor for side effects, and really engage in longitudinal monitoring and continued discussions around the risks and benefits of these medications.
Well, thank you both for joining us today and for walking us through the evaluation of persistent sleepiness in those with well-treated obstructive sleep apnea. Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.